Hello, hello, hello. This is Tooth Be Told. This is a special edition. Dr. Horton's back.
Yes,
I
sir.
think the last episode, if you guys were listening, we actually gave you a little shout out because you wrote an article for Dental Town.
Yes.
So we were proud
Oh,
because
thank you.
you're an alum to this podcast. So we said, why not, give you a shout out. But I got a chance to read the article. You and I just talked prior to recording this, but it's common sense and basic to us now because we went through the whole 3-year perio program. But I love the way you wrote it because it made it make sense on a very just even level without having to read like 20 classic lit articles, 20 modern peri-implantitis articles. You see, you
Right.
basically just summed it up. So I was saying that you basically summed up our first year really well in this article, and so I wanted to bring you on and just for you to just basically tell us why you wrote it and break it down so that our listeners, if they don't want to read it, this could be an audio
The audio
journal.
version, right? Yeah.
The audio journal, you know what I mean? So please let us start from the beginning why you decided to write this.
Yeah, yeah. Well, thanks for having me on, man. I
Oh
love
man, not
coming
at
on the
all.
show. Anytime I've written articles, ever since I think that was my fourth one for Dental Town, really I try to take current events from my life and put it into words, right? And so one of the things I had been experiencing lately was several docs that I've, either mentored or taught over the years still send me cases. What do you think about this? Or, what are your thoughts on that? And, I used to do this before, but probably even more so now after, 1 year of perio. I always, instead of looking at the empty space first, I always look around it, right? What do the surrounding teeth look like? What does surrounding bone look like? From whatever limited information I can get from either a panoramic or a bite wing or a CBCT is what does the occlusion look like? And then I start asking questions, right? I say, does the patient have any health problems? Well, do you know why they lost the tooth? Because there's all these things that kind of give us, I call it, I think I mentioned in the article of being an actuary for the implant, right?
Right.
Because there's a reason this patient lost this tooth.
Mm-hmm.
And that means this particular site in this particular mouth is already at high risk. If you're missing a tooth, you're automatically considered high risk,
Right.
right? Loosely speaking, right? And so when I would ask these questions, often some of these GPs don't know, don't have the answer readily available, right? And so that's part of the motivation from one side. From the other side, being in perio, for better or worse, I'm around a lot of periodontists
Right.
who, especially in academia, can have a certain amount of ego and hubris. And when they,
What?
what?
Ooh,
do,
not us.
do tell, really?
Not us.
But I think I've been getting frustrated lately because there's been a lot of commentary about general dentists, and I've been a general dentist 15 years, and I'm defensive of my brethren, right? Um, because some of the greatest implant doctors or surgeons I know are general dentists, right? But I can see where there leaves a lot of room for someone that is a specialist to have to go back and repair, right? Because a periodontist doesn't see the good work a general dentist has done.
Right.
That's not what's getting referred to you.
Right.
You're getting referred the stuff you got to clean up,
Yeah.
right? And in what I've seen from over the years, the stuff that needs to get cleaned up is usually done in the most high risk situations, right? Patient still has active periodontitis. Patient has traumatic occlusion. Um, Patient has rampant decay. Patient has a collapsed bite. Like usually because there's a reason that the tooth was lost, there's generally a reason why we have to worry whether the implant's going to stay around,
Right. Okay.
And so that's kind of why I wrote the article.
So let's break this down, this article down. You started off by saying you have to know the why.
Mhm.
Do you find that a lot? Because I'll speak for myself. I find that a lot of general dentists don't really ask the why. They want to repair, but they don't want to ask how did we get here,
Right.
right? They want to place the implant. They know, hey, there's an implant that needs to go here.
Mhm.
or this patient needs a bridge, this patient needs restoration, but what caused the patient to need? And that's, I think, like you, I mean, you basically you started that your article by saying the why. And I
Right.
honestly think that maybe that should have been a whole little article itself, because
Right.
we skipped that. And I think as dentists we've gotten away from that, the communication aspect of it, right? Because I
Right.
think once you do that, you'll be able to actually service the patient a lot better. So from your point of view, why did you start with the why? Like, how important is that why for you, and for you to kind of project that to the reader?
Well, it's everything when you think about it. And I can't say I've always been in that mind frame. When I was young and a fresh graduate, you get out of school, you have a limited amount of knowledge and skill set. You're really trying to build your skill set with repetition. So you're just trying to do, right?
Right.
Then as you start getting better, you want to start adding stuff. You're doing some of these more advanced, surgical extractions. Now you're going to start adding implants. So you're just so excited that you saw an empty edentulous space.
Right.
That's all you see, right? And you having gone through the perio program, and me seeing what the education consists of, perio teaches you the why, or to start looking for the why right away. As a general dentist, when you're taking these kind of mix and match of CE courses, you're learning how to do,
Okay.
right? Just like
Okay.
if you're doing construction, you're learning how to build a deck,
Right.
but you're not really asking the why of, why is the ground like this? Why is however you want to
Okay.
form that analogy,
Yeah.
especially because let me take a couple steps back. Because I've been doing it long enough now that I have had cases, and anyone tells you that they don't have failures is either not doing enough implants or
Right.
lying to you,
Yeah.
right?
Yeah.
But I have had cases come back, and my first response always was, well, why did it fail? And what did I miss the first time, right? And as through the years of kind of analyzing my own cases coming back, because a lot of these cases aren't going to come back till like 5-6 years later. And
Hopefully.
you're like,
Yeah.
yeah,
Hopefully they
and
don't
you're
come back at
thinking,
all. But yeah.
right, right. And you start thinking to yourself, and there's a couple cases that came back, and in my head, I was like, how did I miss that?
Right.
What was my thought process when I did that? And so when I do talk to general dentists now, or when we put on our courses, for me, what's really big is doing this comprehensive risk assessment on the entire mouth,
Hmm.
before you put in something that you're hoping to be permanent, right? Because permanent is a long time. you know,
Yeah.
it's a very long
Yeah.
time.
Yeah.
Especially nowadays, we're obviously we're putting implants in 20-year-olds,
Right.
like it's nothing. So we're wanting that implant to last another 50 plus years. And a lot of it is just the why.
Do you think that and I'll get back to your article, but do you think that we are over promising? Because we don't we don't say you're going to have your car forever. We
Right,
don't say you're going to have your house forever. But for
right,
some reason, when it comes to implants, which we use more than we use our car, right?
right.
We like to promise it for a very long time. So are we saying that we're over promising, or are we saying that based on research, this is what we should expect?
Honestly, it's a large overpromise
Yeah.
from my perspective, and I think in my own personal experience, this is just anecdotal, is that especially when I was coming up in the implant continuing education game, a lot of the instructors or the lecturers would tout these 0.5% failure rates over their career.
Right.
And so in your mind, you start, oh, okay, well, if I do it right, it should last a lifetime.
Right.
And we know that with biology, nothing is
That's it.
certain and nothing is permanent,
Right.
or as much as we'd like it to be. So it's definitely, I don't think it's a malicious
No.
overpromise, right?
Mhm.
But I do think, it comes from a lack of experience and
Right.
from an overzealous industry of education where they want you coming back to take more courses. So of
Right.
course, they're going to exaggerate their success rates and outcomes
Right.
and so forth.
Because I mean, orthopedic surgeons don't even do that.
Right.
They don't sit there and say your hip is going to last you forever. They never do
Right.
that. But for some reason, dentistry seems to be the one that seems to do that. But anyway, let's talk about the difference between peri-implantitis and peri-implant mucositis.
Right.
You broke that down beautifully in your article.
Oh, thank you.
Yeah, man.
Thank you. It's sometimes it's a game of semantics, right? It's just like the whole thing, like, can you have gingivitis if you have periodontitis, right? The semantics of it say no, but a lot of GPs and laypersons think of any inflammation of the gums as gingivitis,
Yeah.
right?
Yeah.
But you can also have bone loss with that. But same thing with implants. So in general, the peri-implant mucositis is simply inflammation of the soft tissues around the implant.
Right.
Once you start adding bone loss to that beyond a certain degree, then we start calling it peri-implantitis. And so I think the general dental public kind of uses those interchangeably.
They do.
Um,
Yeah.
and sometimes you don't know because the bone can remodel in the very beginning after placing or restoring an implant, over the first year or so. So, I've seen doctors go the other way with it, where there's maybe a millimeter of bone loss and they're calling it peri-implantitis, but that was part of the natural remodeling.
Right.
But the reason I brought that up, and I think in my article I have a case where instead of jumping to a surgical fix, the first thing I do anytime I see peri-implantitis or peri-implant mucositis is I teach the patient how to meticulously clean that implant. Right. Especially here in residency, we get a ton of patients that get referred up to the grad clinic for peri-implantitis or peri-implant mucositis, assuming that there needs to be a specialist that can take care of this.
Right.
And literally all we'll do is we'll give the patient interproximal brushes, we'll teach them how to floss properly and, with the proper frequency. And then we'll see them back 2 weeks later, 4 weeks later, and boom, everything looks great. And if you can do that conservatively and treat the issue, then there you go.
Right.
But that honestly, it didn't have to be kicked up to us at all.
Well, I mean, I think people are afraid of implants still. So
Yep.
anytime there's anything out of the norm for implants, GPs or anybody, even prosto, will just say, "Hey, send it back to perio, send it back to the surgeon, and let him figure it out."
Right.
So I think we have to kind of demystify implants, and I don't think implants have been demystified yet. I think anything out of the perfect is always scary, and I think
Yes.
that's why we're doing that.
Right.
So let's talk about you had 3 risk factors, and this was actually very interesting to me because you broke all 3 down. But I want you to go ahead and show me, or at least talk to us about each of the 3 factors, and why you chose these, because there's so many other risk factors, right? We could talk
Yes.
about occlusal trauma, we could talk about parafunction. I mean, there's tons of occlusal trauma, parafunction are the same thing, but there's so many other risk factors when it comes to restorative, when it comes to surgical,
Right.
right? That could have been put into this, but
Right.
you narrowed it down to 3, right? And
Yeah.
I kind of wanted to get an idea of why you narrowed it down to 3, and why you think these 3 are so important.
Multi-layers to that.
Yeah.
So dental talent gives me a word limit, and I tend to be pretty loquacious. So I had to pick
Oh,
2 to 3.
okay.
But there was a science behind choosing those 3.
Yep.
I figured a lot of even GPs do deal with occlusion to some extent,
Mhm.
right? So why beleaguer a point that, especially if it's a general practitioner reading this, they're like, okay, yeah, we got it. We've been hammered on occlusion, even just for crown and bridge and so forth, right? I think diabetes is something that's on the rise,
Yeah.
and
In
it's
the US.
often overlooked by GPs as a potential risk factor. Coinciding with periodontitis, especially with diabetes, if there's a presence of inflammation, if there's a presence of disease, that means you're putting the implant in a diseased site. And I'm exaggerating here, but the reason I'm exaggerating is because I've seen so many GPs ignore the patient's periodontal condition, right? Whether it's, clinics that I've worked in or patients that come to me that have clear periodontal disease, 5-6 millimeter pockets, subgingival calculus, but that they've been on a 1-a-year prophy schedule,
Okay.
right? And so I really wanted to hammer the point home that you have to look at the periodontal condition. I wanted to choose a very common, more understood, and easy to swallow systemic condition,
Right.
right? There's a slew of them we could choose, but
Right.
diabetes, I feel like, you know,
Everybody knows it.
everybody knows it.
Right.
And smoking,
Yeah.
because, we still have, what is it, a quarter of the population smokes,
Oh yeah. Yeah.
which is astounding to me that anyone even in this day and age starts smoking. Like, if you're 50, 60, 70 years old, like, okay, I'll give you a pass because
Right.
they marketed it as, helps with digestion, and you had doctors
Right.
advocating smoking in the 50s, right?
Right.
But if it's
Right.
2022 and you're just now starting smoking, like, I really worry about the state of our society. But
It's
it's
everybody's
there.
stressed. Everybody's stressed.
But
So
it's, yeah, it's
let's
there.
break it down. Let's break it
Yeah.
down. Okay, let's start with I like this one, but let's start with smoking since we
Okay.
brought that up. Why does smoking? Why is smoking such a harmful thing to do or behavior to pick up or have when
Right.
you want an implant?
Well, there's a couple things that you need to happen when you put an implant in,
Okay.
right? You need the bone to heal. Um, you need the soft tissue to heal. And one of the things that the nicotine does, and its metabolites, in any form, whether you're smoking it or taking it as a patch or gum, it affects your fibroblasts and their ability to properly form connections, to form collagen. It also affects your osteoblasts, right? So everything that you need to get a nice successful implant, you're being counterproductive by smoking.
So basically building up your soft tissue, healing your soft tissue, and then healing your bone. The two
Right.
important things that you brought up at the beginning is, again,
Yeah.
is what you're basically cutting off when the whole nicotine aspect of it. It's so
Right.
funny. I have patients that'll say, "Well, but I vape," and I'm like, "The nicotine, or
Right.
I chew the, and I knew one of my patients who would chew like 5 of those gums a day.
Hmm.
And I was like, my God, man, like that's a
Yeah.
lot, but again, it's just that hit, that initial nicotine, hit. So you're absolutely correct. The nicotine, very, very well, summarized, but the nicotine is the biggest factor. And I think that's what a lot of dentists need to kind of hone in on when they're explaining to their patient.
They do. And the hard thing that we face is that nicotine acts, one of the things that it does is it acts as an antidepressant, right?
Okay.
So
Okay.
you have a lot of people that, how many patients have you heard that say, well, I usually smoke when I'm stressed out,
Right.
or after work, I got to have a drink and got to have a smoke.
Right.
And so, being that the happiness index in America is what it is, and the stress index is what it is, people are self-medicating,
Mhm.
right? Whether it's with alcohol, whether it's with nicotine. And so that's what makes cigarettes so hard, or nicotine in general, so hard to quit in any form, is that it's not just tied to just a physical addiction. It's tied to a whole psychological and emotional addiction too, because it is a coping mechanism for a lot of people. Um, and we'll have patients that we'll still do the implants in smokers. It's like we do any periodontal surgery in smokers,
Right.
but we got to educate them, let them know your results are more than likely going to be less than ideal. If you do quit smoking a number of weeks prior and stop smoking, or continue the cessation a couple weeks afterwards, it does increase your chances, because a lot of your physiological functions do return to normal within 8 weeks of quitting smoking, but then they'll just start smoking again.
Right.
And we know, as we've talked about, nothing is forever, because the body is constantly remodeling.
Right.
Right? Your bone is constantly remodeling, your soft tissue is constantly remodeling. So yeah, you did what you had to do to get initial integration and success and healing. But those cells that are there today are not going to be the same cells that are there 10 years from now. So now you introduce smoking, those cells that you're going to have 10 years from now are going to be less than ideal.
Right.
And I think that's an important thing we have to hit home. But at the end of the day, all we can do is inform them. It's not an absolute contraindication to providing any treatment.
Right. And I always try to explain, I mean, you said it, I always try to explain to patients that, if you have plaque, which is our biggest, I mean, we're fighting plaque all the time. If you have plaque biofilm, we know that that's going to cause an issue. And
Right.
if you're not able to heal yourself, if you're not able to fight those bacteria because you're smoking, and that's preventing us from being able to really get in there and fix the damages that bacteria has caused, then it's just going to continue to get worse.
Right.
Right. And like you said, you may have initial, healing, excellent healing, but then it's going to progressively get worse as time goes along.
Right. And one of my things that I've stolen from one of my faculty members here, Dr. Hokett, is I like to use the line that you have to be an oral hygiene athlete, right?
Okay.
So if you're going to continue to smoke,
Mhm.
it's just like if you are taking blood pressure and cholesterol medications only so you can keep eating McDonald's, right? You're not changing anything else,
Right. Right.
right?
Right.
Like if nothing else, if you're going to keep up the smoking, you have to make sure that all the ancillary stuff to that is elite level athlete,
Yeah.
oral hygiene, showing up every 3 months for your cleanings. If you're not going to quit smoking.
Right.
Now, if you're not going to quit smoking and I'm only going to see you every 2 or 3 years, then I may not want to do the implant on you.
Okay.
Right. So there's a balance. There's a gray zone.
Right. Right.
And you have to trust that your patients will at least do the minimal enough to give themselves a reasonable chance at long-term success with these implants.
Patient selection. So let's
Yeah.
talk about diabetes. Break that
Mhm.
down for us. Why? I mean, like basically, why diabetes is sometimes a contraindication for, or uncontrolled diabetes, I should say. Sorry.
Right. Well, one of the things that happens when you're chronically hyperglycemic is that it affects a lot of the cells in your body, right? And one of the things I didn't mention to smoking, which is the same thing in diabetes, is the effect on the neutrophils, one of your white blood cells, important part of your immune system, right? And so when your immune system is compromised, when again your fibroblasts and your osteoblasts are compromised, we know with diabetes, high blood sugar levels lead to advanced glycosylated end products, right? That attach to proteins and cells and inhibit their function or make them more susceptible to degradation by inflammation. So you really have
so let me stop you real quick because
yeah.
what you said right there might have right. So
Right,
basically,
right.
what he's saying is just consistent, continuous inflammation. Your
Yes.
body doesn't like to be in a state of just alert, right? And
Right,
that's basically what you're putting your body in a state of alert, flight or flight
right.
in a way. I mean, this is me kind of simplifying it to a very extreme,
Yes.
not as poetic as he put it, but again, your body is like, hey, there's a problem, and if your body
Right,
is continuously saying that, sooner or later you're going to burn out.
right, right. And honestly, and you've seen it from both ends in both those risk factors, right? Smoking and diabetes. On one end, you're making it so that there's hyperinflammation, okay, to one degree or another.
That's right.
On the other end, you're decreasing your body's ability to rebound.
The smoking
So you
part.
got a destructive process here,
Yep.
and you're handicapping your ability to rebuild itself.
That's it.
So in the end, it's a net loss
That's
over
right.
time.
Yeah.
And that's why I tell patients, like, you got to choose your poison, right? If you're not going to give up the bad habit, or if you're not going to take better care of your systemic health, then your game, your oral hygiene game, your compliance game, coming in for your cleanings every 3 months, has to be on point. Otherwise, I can't give you a confident assessment of how long what we're going to do is going to last for you.
So he's basically being nice by saying that, listen, if you're not going to smoke, if you're going to continue to smoke, make sure you're in there every 3 months so that we can
Exactly.
clean you, right? So you got to give up something. You got to give up your time, or you got to give up the smoking, right?
Right. And this is where it gets back to the general dentist. In all the offices I've ever worked in, it seems like there is an aversion to recommending more frequent cleanings for patients.
Yes.
Why? Because on a certain level, you're playing the insurance game,
Mhm.
right?
Mhm.
Some insurances may or may not cover more than 1 to 2 cleanings a year. And also it's this game of, not wanting to seem like you're money hungry. And when
Okay.
all these other dentists are saying, oh yeah, we only need to see you once or twice a year. And now you're saying, I'm sorry, you really would benefit from 4 times a year. The patient is like, well, wait a minute, why are you giving me
Right.
4 times a year and it's
Right.
not covered by insurance? So I got to pay out of pocket. See, when me and you say it, when you're in a specialist position,
Yeah.
there's an assumed expertise where if a specialist is saying, hey, you got referred to me, this is what you got, this is what you need,
That's it.
it's accepted better.
Yeah. True.
when the GP says it, and this is where, when years ago, I was frustrated with a lot of my associates that either wouldn't really pay attention to the periodontal health. And so I tried to build a hygiene centered practice. So I really sat down with my hygienist every month. We talked about strategies, how to how we were going to diagnose, how we're going to talk to patients, and so forth. And there was resistance hearing that from me or my hygienist. You know what I'm saying?
Mm-hmm.
But I feel like it just in my 1 year in residency, I don't get nearly that much resistance. And the only thing I can assume is that it's potentially a more accepting patient because they already made the trip to me. So that shows a level of commitment there.
Okay.
The ones that probably wouldn't have accepted wouldn't
They're
even
not
bother to
come.
come.
Yeah.
Right. And then given that there's this kind of expectation that, hey, if I have this advanced disease that I had to be referred to somebody, let me listen.
That's okay.
I really don't have much pushback from anybody, but in the GP world, I got it all the time.
And that's actually, I never even thought about it like that, but that's very true, right? Like anytime you go to a specialist, people assume, okay, there's another level there's another level there. So whatever
Right.
they say must be true, right?
Right.
If I go to, we'll say the Mercedes-Benz, I've never been there, but the Mercedes-Benz dealership and I get my car fixed there, I'm assuming that everything they're saying, even though it's at a higher price, is completely correct because they specialize in this vehicle versus
Right.
going to my local, auto dealer or local, repair shop, right?
Right.
So yeah, it sucks. It actually does suck because there's a lot of dentists out there that are trying to do the best and for their patient. And so patients, if you're listening, you have to kind of understand. And this is when I think asking questions comes into play.
Yes.
Because if you sit down with your dentist, and this is also for you dentist, if you sit down and listen, not just tell people, but listen, you may be able to get more out of the patient. And the patients, you guys got to ask questions. Don't just sit there and go home and be like, oh, yeah, that dentist's trying to rip me off. Ask questions. Why are we doing this? Is it because we just want to see you 4 times? No. I don't know a single dentist that wants to see their patient 4 times for the fun of it.
Right.
You know what I mean?
Right.
We want to see you for a reason. You know what I mean? And so I think those are the discussions. We need to have more questions being asked, and we need to be able to explain our treatment plans or our logic a lot better.
Right.
And
but I don't know if
probably what happened. Maybe. What do you think?
I think so, and I also feel like the industry doesn't support that. Right.
Right.
One of the luxuries I have in school, although I'm seeing way less patients per day, I'm seeing them for more time.
Yeah.
So the level of discussions I'm able to have with patients, the rapport I'm able to build, the trust, the explanation, because in school you're seeing one patient maybe 2 in the morning, one patient maybe 2 in the afternoon. In private practice, you're seeing 30 patients a day. Right. And so when you rush in, they've been rushed into the room. They can tell everybody's scrambling. You're talking to them real quick. They get the sense, unless you're in a fee-for-service office and kind of built a slower, more patient-friendly schedule. Patients know that, hey, they're trying to crank me out. They're trying to make money, not necessarily in a bad way, but it's business, right? And I think that kind of adds to the atmosphere of, okay, I see you're trying, this is a factory, and now you want me to come back more often. I don't know. I'm putting 2 and 2 together, and I just see dollar signs.
Okay, that makes sense.
But again, that's all conjecture. I mean, that's
this is why we're here. We're not saying that we're 100% correct, but we're saying, hey, this is our opinion.
Right.
That's our opinion. And then the last one, and I thought that, I'm not biased or anything, but I think it's the best one. Periodontal disease. I absolutely love the fact that I get so many patients that come to me with full-blown period disease. I'm talking about active 5, 6, 7 millimeter pockets with mobility and bleeding and pus and stuff. And the first thing they say to me is, I want to get implants.
Right.
And I'm like, that's nice. That's nice. Good for you. I'm glad, but I'm telling you, and I tell them, I'm like, straight up, be honest with you, you're probably looking at like 2 years out before I even feel comfortable placing an implant, because I gotta get that foundation correct. So break down why implant disease or periodontal disease, it's such a risk factor for periimplantitis.
Okay. Well, let me paint this in a way that I understood it as a GP coming into the game.
For sure.
You get two siblings come in, right? Usually it's the boy and the girl. The girl brushes, seems to do a great job. Every time she comes in for exam, it's not much plaque or calculus, but she always has one or two cavities, right? The brother comes in and it's just a hot mess. You could tell he never brushes, never flosses, but never has any cavities. And in the GP world, we've understood that it's not just sugar that causes cavities. You have to have the right type of bacteria that are active, right? That are motivated to eat the sugar, create the acid. And so you could actually have a person that does not have a good diet, has a high sugar diet, but rarely ever gets cavities because the bacterial the bacteria that's needed to be there isn't there or is lazy, right? It's the same thing with periodontal disease. So someone can systemically just be predisposed to a hyper response to any type of plaque, calculus, foreign material, period, right? And some people are not. But if you know someone has periodontal disease, that's going to tell you that whatever that inflammatory process is that is destroying the support of those teeth is going to be there and is going to be all around that implant, right? And that's the biggest thing. If we're wanting to at least be confidently say, hey, you're going to get 10, 20 years out of this implant, we want to make sure that we're putting it in a mouth that has like you said, a healthy foundation where we've at least stabilized the periodontal disease and eliminated as much as possible that chronic inflammation. And the only way to do that is, periodontal therapy, compliance. They're coming in every, 3 months for their cleanings, and they're oral hygiene athletes. They need a gold medal in brushing and flossing and, right. Because if you know that you're automatically systemically more likely to have inflammation, you want to make sure you're not feeding that inflammation by not taking care of your mouth.
And you mentioned a study with identical and fraternal twins,
right?
And you were talking about like their susceptibility based on genetics. Can we just brush up on that? Because I thought I was really interested, and I wanted to brush up on that because a lot of people say, well, my mom and dad or whoever had it, so I have it too, right? And then other people just blame it on kids, but that's another story for another day.
When I was pregnant, the baby took all the calcium out my teeth, right?
And I'm like, you remember when you gave birth and you didn't brush for like 4 days because of being an awesome mom? And, I always talk about that. I'm like, you got to stay in this other factor. You can't keep blaming the kids for everything,
right?
But let's talk about that genetic component part of it.
Well, just like there's genetic components to a lot of systemic diseases or autoimmune diseases, the inflammation in the mouth is very similar, right? So, but we've got to put that into perspective. That doesn't mean if your mom lost her teeth, your grandma lost her teeth, and same thing on your father's side, that you should just have a defeatist attitude and say, well, I'm not going to invest in my mouth because all my family's got dentures, so I'll probably have dentures too. There's nothing I can do, right? There's absolutely stuff you can do. Is it going to be 100% guarantee fixed or, going to arrest the disease? No, but we can. A while back, you mentioned the click and talk, the ticking clock.
Yep.
Right. On implants.
On implants.
It's the same thing with the inflammation and periodontal disease. Right. So if we know that you're predisposed to this hyperinflammatory response, we can tailor your treatment so that way we can buy you a lot more years out of your natural teeth, which is what we prefer to have, right. And also any implant stuff that you're going to have done. But there's often, they say that, the genetic contribution is about 50%, right, to anyone's periodontal disease at any time. But the other 50% is within your control, right? How you brush, how you floss, what you eat, how frequently you go in for your cleanings, and then how amenable you are to the evolution of that treatment recommendation that we're going to give you, right? Because we kind of have a standard treatment that we might recommend someone that has a certain presentation, and it might work for 80% of patients. But if we're seeing you regularly, and if we're seeing we need to be more aggressive or less aggressive, we can tailor it to you. But you have to be amenable to that. and be proactive, especially if you know that you're predisposed. So when I do hear patients say, oh yeah, my mom was in dentures by 30 and my dad was in dentures, I tell them like, that's the high alarm. That's the red flag. We can still do something for you, but you have to be 100% committed, and that might be someone, especially depending on their presentation, I may want to see a certain amount of commitment for, like you said, a year or two before I am brave enough to put an implant in there.
Right. Right. And then I think you mentioned that sometimes people just are not candidates, right? Because all the factors. I mean, if somebody comes in who is a smoker, has high diabetes, has uncontrolled diabetes, and lost like 5 teeth already due to periodontal disease, guess what? You're probably coming off that implant list big time.
Yeah.
Right? You're coming off that implant list big time. Some people will have a solution. Well, we'll just take all your teeth out and then place implants because now we fixed the problem. Well, no.
Right.
Well, because why did they have perio? Was it because they had poor oral hygiene? I think, and this is me kind of coming off your getting away from your article, because your article is incredible. People really do need to read it, and if we can, maybe we can add like a link to in the show notes for people to actually read it. But one thing that I've noticed is oral hygiene. You cannot substitute for that, right? Implants, having an implant, you have to do more. Having fillings, you have to do more. I tell people,
Yes.
I've noticed this, and maybe you've noticed this too, but whenever people have crowns, those areas are the ones that usually have deeper pockets.
Right.
And I'm always telling people that you have to do more when you have crowns, because that's not the natural shape of the tooth. We try our best, but that's not the natural shape of the tooth. And another thing too is, let's just say you take all the teeth out and you do that, tooth in a day. That's how we're advertising now, right? We're doing tooth in a day, but why can't I want a tooth in a day, like it's Christmas or something.
Right.
You've made it harder actually to keep that area clean, because it's not, again, you can't floss like you normally do. You have to be taught a lot more. And some people just get these implants, spend thousands of dollars, and no one teaches them how to keep it. So that's another factor. And I know if you had more time, you probably would have broken that down and been like,
oh, absolutely. Absolutely. And that's one of the things
implant.
When you're talking about assessing risk, it's, you look just like with the insurance companies, right? The longer your accident rap sheet is, right, the more your premium is going to be. We have to assess it the same way. Not that we're charging them more, but as far as our decision whether to even place them, right? If someone can't commit to at least changing their behavior to take care of their existing teeth, I'm not going to want to put implants in, right? Because like you said, especially if you go even to a all-on-X prosthesis, cleaning that is substantially hard. And you've seen, I don't know how many prosthodontists you work with, you've seen the evolution of the design of these prostheses. From, they used to have flanges to kind of give a more aesthetic appeal, but you can't clean them underneath, and you got these prostheses that are being taken out to be cleaned, and they're full of bacteria and fungi, and inflammation, and you're losing bone around your implants. So now you have more hygienic designs that sometimes are sacrificing aesthetics, but you realize that, well, do you want compromise in aesthetics, but you can have this for 10, 15 years longer, or do you want me to do the old design, and in 5 or 6 years we'll be pulling some of these implants out?
Right. It's a battle, man. It's a battle. But I think one thing that you have to do is have respect for implants. I personally, and this is just speaking for myself, I feel like everybody's gotten very implant happy, without the proper fear for implants. And I'm not saying don't do implants because they're scary. I'm just saying have the respect for implants, because you realize that you are doing something that is not 100% natural, right? We're not, we're trying to replace a tooth that had fibers around it so it could take shock. Implants don't have fibers, they don't take shock. A tooth that was able to be, more malleable, we've eliminated that, so grinding, people that maybe aren't the best at brushing and flossing, a natural tooth could kind of give you a little gray area. Implants is it's very close to all or nothing in a way,
It really is. And that's why I developed over the last few years, as I've been doing some traveling implant work, a referral form that the docs I work with will fill out, and their staff will email it to me before I even get in there. And it has questions like, what medications are they taking? Is there any systemic conditions? Is there recent charting? What type of, periodontal diagnosis or frequency of cleaning they're getting? Because at least I want the general dentist to start thinking along those lines, right? Before they even kick up the patient to the next level. Right. And I usually have extensive conversations with them and tell them what to look for and why. And I wish someone had done that with me, because literally when I was learning, it was the scope of the education began at the mesial or the distal of the front tooth to the mesial of the tooth behind the edentulous space. And that was it. That's all we were learning about, was that,
Let's
and I
focus
think
in
that
the empty space.
yeah, and that does such a huge disservice, not only to patients, but also to the provider, whose responsibility is to look out for these patients.
That's awesome. Well, let's, and I know you're a busy man, and I definitely could sit here and talk. As everybody knows, I can talk dentistry all day. But I think your article is very well summed. I mean, sums up very, very complex situation, right? I think that's what we kind of have to acknowledge, that you pretty much summed up multiple research and kind of said, here, let me just give you the the cliff note version
Right.
of everything, right? And that's exactly what you're doing. But I do believe that anybody that's listening, anybody's going to read the article, I think you need to kind of expand on that and just say, okay, well, why does nicotine cause this, and why? So knowing the why again, I think will help you to be a better clinician. Period.
Yes.
Right. So I think that's what we need to start doing. We need to become better clinicians by learning the why. I think that should be the title. Learn the why. That's your next article, man. Learn the why, and then we'll go off of that.
Exactly. And honestly, I mean, you hit the nail on the head with that statement. And really, one of the overlying themes of all my articles is I have been and always will be a general practitioner at heart. And I know the struggle of what it's like to be trying to piece together all these bits of information you're getting as you're trying to expand your skill set. And I'm really trying to build small articles and small curriculums that really help the general dentist have a greater understanding of the specialty work that they're diving into. And I think that's, if I can do that I think over the next 10, 20 years, as I'm trying to pursue my academic career, that'll be what I'll rest my hat on, is the fact that I really contributed to the breadth of knowledge for the general practitioner, as implants kind of become the future of a lot of dentistry.
Right. I'm gonna leave it there.
I'm gonna leave it
there. I felt like that was the perfect way to end it, so I'm gonna end it right there.
Yes, sir.
But thank you, Dr. Horton, for coming back on. Honestly, you're definitely like an honorary guest. Anytime you want to come on, you're more than happy to come back on. But thank you again for writing this article. I'm definitely gonna add it to the show notes so people can go ahead and read it, or just listen to this podcast, whichever one works for everybody.
Right. There you go.
I mean? So we'll put that up there and we'll go from there. But I thank you, sir. I appreciate you as always, man. Enjoy your night. Take care of yourself.
Take care.
All right, brother.